the images have identified automatically that there's a large vessel occlusion. And if you were having trouble finding it yourself, which you shouldn't, it's colored in with a little red box. So we know that this patient has a occlusion of the right M1 segment. And we can see that in different views, or we can spin it around. So it's helpful. We don't have to dial in on our computer to see the images. They come out on the phone. And then this is an automated aspects score. Particularly at 4 a.m., it's very hard to do an aspect score because your vision is blurry and aspects are pretty subtle. So we can see that there is some early infarct changes in the deep areas. And you can get a low aspect score if you have small volume regions involved. If you had added in the insula and one M1 segment, this patient would not meet AHA criteria, but still has a small infarct volume. So again, we're not as interested in the score as the volume of tissue that's irreversibly injured. And we always prefer the CT perfusion to the aspect. So here we have the CT perfusion, which in this case matches pretty well. It shows us that we have some region in the basal ganglia where the CBF is very low, and this is tissue that's not salvageable, but there's a huge penumbra region here. So what we are left with here is a patient who is 7.5 hours since she was last known well, who's got an MCA occlusion and a large amount of salvageable tissue. So I'm not going to ask you to vote on what to do because it should be pretty obvious. This patient clearly meets the diffuse 3 and the Don criteria, even though in the late window they should get thrombectomy. And we'll talk tomorrow about whether they should also get TNK or TPA in the late window. So now let's take a call from an outside hospital. So this is a hospital in Monterey, California, a beautiful place to live, but they don't do thrombectomy. So when they get a case that they think might be a thrombectomy, they call us. And as soon as we get the call, we pull out our phone because we automatically get their images at the same time they do, which is very helpful to make triage decisions on who to transfer to your hospital. So this is a 62-year-old woman. She has hypertension, diabetes. And that afternoon, at about noon, she developed some confusion, dizziness, and some left-sided numbness. The emergency room doc has access to these images, and he says that the automated CT angiogram is not right. It is showing some yellow color. And that's about all. Our ER docs at these centers usually are not ones to take a look at much neuroimaging. So we open the images and we can see this, and indeed there is a yellow color. So what the red color on the previous one I showed you meant there was a very severe reduction in vessel density corresponding with that M1 occlusion. This is a less severe reduction in vessel density throughout the right MCA territory, but what we really want to look at is the actual image, and if you look at that image, you can see that this is not your typical M1 occlusion. In fact, it looks more like an atherosclerotic type stenosis. It doesn't look like a complete occlusion. So now the perfusion imaging becomes even more important because we're not sure that this is an M1 occlusion. It looks like a stenosis, and the perfusion imaging is going to support that. Here we see none of that green area on the Tmax. So this mismatch map is going to show us more than a 6-second delay in the perfusion, and none of that right MCA territory has the 6-second delay. The bright areas that you can see in white show that there is some delay, and then we don't see any pink. So there's no area with severe reduction in cerebral blood flow. So we're wondering what's going on. Here's another look at that perfusion delay. The blue color indicates a 4-second delay in perfusion. So probably in the region of benign oligemia rather than critical hypoperfusion. And then we get the image columns that give us the CBV, CBF, mean transit time, and Tmax. And these are co-registered to the non-contrast CT. So what you can easily see is that this patient has had an old infarct in the right middle cerebral artery territory. But right now, there is no area outside of that old area of infarct that has hemodynamic abnormality. So probably what you'd be thinking is that this is somebody who is having some manifestations of her old infarct rather than a new occlusion of her MCA. So unmasking of an old deficit, and this is not a patient that we're going to put in a helicopter and fly to Stanford. because we're not going to go into that middle cerebral artery. The damage that we're seeing in this patient is old. We don't have any evidence of new ischemia in that territory. And it's not uncommon that in somebody who's got a urinary infection or a chest x-ray abnormal because they've got bronchitis or they've had some change in their medicines, to have unmasking of their old deficit because of that intercurrent illness. So again, the imaging really changes our approach, where we're not going to fly that patient to Stanford. Okay, here is another community hospital that we work with, which is not as sophisticated with their imaging. They don't do CT perfusion, they don't have rapid, we can't get their images, so we have to just listen to what they tell us. So this is a 69-year-old female with coronary artery disease and hypertension. She presents with left hemiplegia, and they treat her with TPA because she comes in within 3 hours of symptom onset. She still has the left hemiplegia. Their CTA they've read as having a right M1 occlusion, but no major early infarct signs on their plain CT. They're not familiar with the aspect score at this hospital, but they tell us if they see a lot of dark on the CT, and they don't. So what are we going to do? We're going to take her, of course, and fly her to Stanford because we think this might be an M1 that needs thrombectomy. And she arrives at Stanford within 5.5 hours after symptom onset. So a good question would be, should she just go straight to the cath lab? We heard some discussion about you don't really need advanced imaging if you're in the 6-hour window, and she's within the 6-hour window. So one option would be to go straight to the cath lab, but that's not what we do. We would image this patient, and we have many, many times where the images show us something that's going to change what we're going to do. So here's her image. 5.5 hours after she had her deficit and supposedly had a right M1 occlusion, which she probably did have before she got the TPA, but you can see that the TPA did something for her. It opened up one of her M2 segments. So the superior division is now open. You can see that there's no perfusion abnormality in the superior distribution of the MCA, but the inferior division is still occluded. So she's got an M2, it's a large M2, but what's the problem? What's the problem with opening that M2? It is totally matched. This is dead brain tissue. So I could have taken her straight to the cath lab and without doing any imaging, and I would have seen this large M2, and we probably would have opened it. But one of the things that you can see, and we just saw an example of that, is when you have a tissue that's dead, and you return blood flow to a large swath of dead brain, you run the risk of hemorrhage. And when you're going after an M2 in general, you run the risk that it's a higher risk vessel to go into. So I think that imaging prevented a procedure for this patient that, one, had some risk associated with it, and two, was not necessary. So again, this is part of our rationale for why we like to get that imaging even when they're in the 6-hour window. The other thing that we can see from this imaging, if you look really close, is she's got some bright dots in her opposite hemisphere. So that's going to be a clue that this is not just a simple M1 occlusion. Something's going on causing some embolization. So there's a wide differential for that. But one of the things that you may want to be thinking about is looking for paroxysmal atrial fibrillation or other causes of embolization from proximal sources. So decision-making was not to do endovascular therapy and to continue the workup to look for a stroke etiology, and she was found to have paroxysmal atrial fibrillation. Okay, so I want to go into a little bit more of this issue about, is repeat imaging necessary when you're transferring a patient to your hospital for thrombectomy? And I think the answer is that if we know the collateral status of the patient, we can make a much more informed decision. So the way that we like to look at collaterals is by this degree of severity of the Tmax. So again, the Tmax perfusion parameter is looking at how many seconds of delay is that contrast arriving in the ischemic hemisphere. And if it's more than 10 seconds of delay, it'll show up as red on this map. And that is by definition bad collaterals. It's taking more than 10 seconds for that contrast to get into the ischemic region. This is a patient who has terrific collaterals because even though the MCA is occluded, it's only a mild reduction. Most of it is 4 to 6 seconds of delay, and then a little bit that's 6 to 8. So we have a parameter called the HIR, which is the hypoperfusion ratio. And it's looking at what percentage of that Tmax6 lesion is red. And in this case, it's 0. There's no red at all. So that's an ideal hypoperfusion intensity ratio, and that means the patient has great collaterals, even though the patient has an aphasia and a hemiplegia. Here's another patient who looks the same in the ER. They have an aphasia and a right hemiplegia, but you can see 80% of that Tmax lesion is red. So this is a very bad hypoperfusion intensity ratio, and this patient has bad collaterals. And what we found in a number of studies is that if you have the bad HIR, you grow fast. Your core grows quickly. And if you have the good HIR, your core grows very slowly. So this was a study that we did just with the single hospital. It was that community hospital of Monterey that I just mentioned, right, that had the yellow overlay on the CA in that case. Took all of the cases from that hospital over a period of time. They had the rapid imaging with this perfusion imaging at the primary hospital. We sent them all to Stanford, and we got an MRI scan on arrival on every single one, and we looked to see how much core growth had occurred. And what we found is that if you had the favorable HIR, if it was less than 0.5, so less than half of your perfusion lesion is red, that these patients had minimal to no growth during the transfer. Okay, so you could say for those patients in the future, we could go straight to the cath lab because they're not growing. On the other hand, the other half of the patients who had a HIR of more than 0.5, they had substantial growth. They had a growth of about 10 ml per hour, and this hospital happens to be 3 hours away from Stanford. So that means a substantial number of these patients had completion of their infarct if they had high HIR. So again, this is going to give you the ability to make a decision, you know, can I go straight to the cath lab, or is this somebody likely to grow that I really want to image again? Okay, I'm going to finish up by just showing you a few cases of what we list under our challenging decisions. Right, so every thrombectomy we do, we have a group of us which has neurologists, vascular neurologists, diagnostic intervention radiologists, the interventionists. We all get together and we do something we call the Monday morning quarterback. I don't know if that's a term that you would know here. It's that there was a football game on Sunday, and on Monday you review to say all the things that went wrong or went right with that game, right? So we review to say, you know, did we make the right call? And these are the type of cases that we struggle with. Large core, low NIH, M2 occlusion, pediatric, or a 90-year-old. So I'll show you a couple. So here's the large core examples. 58-year-old male, left M1 occlusion, high NIH scale, early, 3.5 hours. And you can see that the diffusion lesion shows that 75 ml of tissue is dead. And they also have a very large mismatch, right? The mismatch volume is 116 ml. So the question is, do you want to do a thrombectomy on a patient? This patient would not have been eligible for extend IA, would not have been eligible for diffuse 3 because the core is too big. But for clinical practice, we treat things differently than in a clinical trial. In a clinical trial, you have to have very fixed rules, right, that you're not going to break. But here we're going to look and say, where is the salvageable tissue? Where is that 116 ml? And if you look at where it is, it's in some pretty important real estate, like the motor strip. Okay, so even though we're worried that there may be a slightly higher risk of brain hemorrhage with that large baseline infarct volume of 75, this patient has a lot of important tissue that can potentially be saved. We also can look at some of that area that it has the potentially salvageable tissue, and we see that the collaterals are very good there. What we found is that the CBV map is actually much better for collaterals than it is for core. And where we get the core is the CBF map, that very blue low CBF. And I see a couple of cases that you've shown where the CBF has been very low. When you reperfuse, that tissue is already dead, right? So what we're seeing is a lot of salvageable tissue in some important areas. So we go ahead and take the patient to thrombectomy. Fortunately, got a TICI-3 reperfusion with one pass. We don't expect any of that initial 75 to go away. And because it's going to take some time to reperfuse, often the infarct volume will be bigger than that initial 75 ml. And if you can see the 24-hour follow-up, you can see it is a little bit bigger, but look at the areas that saved. All of that anterior hemisphere, including the motor strip, have been saved, and we didn't cause much in the way of hemorrhage. You can see on the GRE, there's some tiny hemorrhagic transformation, but that hemorrhagic transformation was in tissue that was already dead. So that didn't make the patient any worse. Patient wound up with an NIH of 6 at discharge, which we think is probably much better than they would have done without the procedure. So again, it's a little bit of a border zone because it's large core, but there are ongoing trials looking at large core, and our suspicion is large core, large mismatch, those patients are going to benefit. Okay, here's a little bit of the other end of the spectrum. This is a low NIH case. So 79-year-old woman with hypertension, hyperlipidemia. She wakes up with a mild aphasia. She's got a right upper extremity drift and some dysarthria. So she's not hemiplegic. She's, it's mild. And it adds up to an NIH score of 5. But her CTA shows that it's an M1 occlusion. It's distal, but it is an M1 occlusion. So let's take a look at what she's got at risk. And again, even though that this is a mild NIH stroke CL, there's a lot of pretty important brain tissue that's in the green zone there. So we're worried about this. On the other hand, if we have a low NIH score patient, particularly if it's an M2 occlusion, and the green region is very small, then you have to say, look, I'm looking at what's going to be a small infarct. And do I want to take a risk of rupturing that M2, right? So this is a case where we decided we want to go after it, right? This is actually a distal M1 rather than an M2, and there's a substantial mismatch. So we go in and do the procedure, and here's the post after that nice successful procedure. We got the post scan, and you can see that the diffusion lesion continues to be small, completely reperfused, and the patient did great. So that one did well. Okay, how about kids, right? We've had this amazing success with thrombectomy in adults. So why should a 15-year-old who has a cardiac disorder and throws a clot into the M1 not get thrombectomy? What about a 12-year-old? What about a 5-year-old? And what about a 2-year-old? We need data. So we're hopefully about to start a big trial called PETITE, where we're going to be specifically looking at patients between 5 and 18, but also in a registry arm gathering data on some of these very young patients who are now being treated. Some of the endovascular therapists are quite aggressive in the US. They're taking the babies to the cath lab. It may be dangerous. We also don't know what's the best way to identify penumbra in kids, and we suspect it's different than in adults. So here's a 10-year-old girl, healthy, found at 2:30 p.m. at the bottom of a slide. So described as an unwitnessed fall. She's taken to the Stanford emergency department, and I can tell you that stroke is not the first thing that comes to mind when a 10-year-old who's found at the bottom of a slide comes in. It's some type of trauma, right, that they're thinking of. And a little bit embarrassing to say is that they didn't activate a stroke code for 2 hours, right? They missed that this patient was having a stroke, and that's often the case in kids. There was an attempt to do a TPA trial in children, and it completely failed because they never identified the stroke within 3 hours in kids. But now with the 24-hour type window, we think that we can do a thrombectomy trial because a lot of these patients are late window. So here she is being identified with a M2 occlusion now quite a few hours after she had first had her fall. So here's the imaging. And what we've been finding in the kids is that rather than using the 6-second Tmax threshold to identify penumbra tissue, we've seen many children whose clinical deficit corresponds with that 4-second delay. So we think for kids, the threshold for penumbra is going to be different on the neuroimaging. So that's one of the important things we'll be looking at in PETITE. So here you can see here, she doesn't have a mismatch using the adult criteria, but using our children's criteria, she does have a mismatch, and she still has a significant clinical deficit. So we took her to the cath lab and had a nice recanalization of that large M2. And here you can see all of that blue area that seemed to be clinically relevant because she was still aphasic when she went into the cath lab has been saved, and she wound out with an excellent outcome with an NIH score of 2. So we've done about a dozen kids with this type of imaging, and that's what we're trying to put into a 25-center trial. I'm going to finish up with, again, the opposite end of the spectrum from the kid. It's the 90-year-olds. And the 90-year-olds essentially were excluded from most of these trials. If they didn't have a cutoff of 90, there were very, very few 90-year-olds in there. We have had success in treating some 90-year-olds who are in really great shape. These are the 90-year-olds that are out on the golf course and fully independent. But now that the floodgates have opened with thrombectomy, right? That people are so excited that the results are so good, we get a tremendous number of calls for people in their 90s. Often these are people who are quite disabled at baseline, even though when the doctor calls, they don't tell you that. They say the patient was doing well because they want you to, the family wants to give grandma a shot. So here's a 93-year-old with left-sided weakness and neglect, and we do the imaging, and she's got pretty good collateral, because you can see there's just a teeny amount of positivity in the insula. It's not enough to trigger our threshold of the ADC less than 620, so we don't see any pink there. We can see part of the way she's got good collaterals is that with a M1 occlusion, she doesn't have a huge green perfusion lesion. So since she was supposedly pretty functional at baseline, we took her to the cath lab and went ahead and did the thrombectomy procedure, which went quite well. And you'd think, well, the patient could do really well, but what we see over and over again in these over 90-year-old patients is this type of problem. It's not the brain, it's something else that leads them to do very poorly, and then the family will decide to withhold care. So here's our series. This is just a recent series where we looked at our 90-year-olds and compared them to our 80-year-olds. And it's pretty clear from the clinical trial data that 80-year-olds who are appropriately chosen for thrombectomy will benefit from the procedure. The benefit that they get is not having a full recovery from their stroke. The benefit that they get is avoiding that rank in 4, 5, and 6. Getting them into the 2, 3s, and 4s, and out of the 4, 5s, and 6, that's the benefit we see in the 80-year-olds. The 90-year-olds, we are not so sure that we're helping them with thrombectomy. There may be some, but look at the death rate. And again, oftentimes it's not dying from the stroke. They have good recanalization rates, although not as good as the younger patients because their vessels are so tortuous, it can be hard to access the clot. But this is an area that needs more research. So these are some of the areas that people are looking at in future trials so we can get more data to make better decisions on these tough cases. All right, it is, I think, 6 p.m. and probably time to wrap up the symposium for the day. But again, thanks for inviting me. I really enjoyed the visit. Thank you.
Thank you very much, Dr. Albers, for your presentation. We have a few minutes before we finish the session. Perdón, tenemos unos minutos si tienen algunas preguntas que quieren hacer. Una de las exposiciones. Doctor Rex.
Bueno, muchas preguntas en realidad, muy interesante todas las paradigmas. Mi primera pregunta es fueron publicados en The Fuse en pensamos que el doctor Mena se venía definitivamente de vida acá en la clínica y otro país. Tenemos una ventana terapéutica de 6 y 8 horas hasta las 24. Y entendiendo que hemos tenido pacientes, digamos, con trombectomía en esa ventana terapéutica, no es un número tan grande. Entonces, probablemente muchos pacientes que pasadas las 6 a 8 horas ya tienen su infarto completado o ya lo tienen y otros susceptibles de ser recuperados. Esa es la pregunta: ¿qué porcentaje de pacientes con encefálico y oclusión de vaso visible tienen
mismatch o tienen posibilidad de un tipo de cada uno de 6 a 24 horas. Por ejemplo, el número de pacientes en general.
Yeah, it's a great question. So in terms of the first part of your question, why is Dr. Mena not in the hospital all day and all night? Well, there is a substantial number of additional patients who are eligible for thrombectomy now. So start with the wake-ups. In our area, about 25 to 30% of our stroke patients are wake-ups, right? So these are patients who are not eligible under the 6-hour window. So right there, you're increasing your volume by about 25 to 30%, because the majority of wake-up stroke patients probably had their stroke in the relatively early hours, and they're in that category that we said where about 75% of them are going to have the favorable profile. Okay, then when you go to the non-wake-up stroke patients, and you look at the typical non-wake-up stroke patients, Fuse 3 or Dawn, these are patients on average who are seeing at about 12 hours after last known well. And if we look at that point, we see that about 50% of those patients will have the target mismatch profile if they have an MCA or an ICA occlusion. Now, many of the patients who come in that time window, they don't have an MCA or ICA occlusion, right? So those aren't going to be included. But if you say patients who could have been treated in our 6-hour window because they had the right vessel occlusion, right, and you would have treated all of them, right, assuming you're not imaging, you're just treating them all, what percentage of those were eligible in the late window? It's 50%. So it's an important number. And at Stanford, after Diffuse 3, our thrombectomy volume doubled in the year after Diffuse 3. So that's about what we would have expected. Now, there are other sites where that didn't happen. So one of the reasons that happen is if you're in a big city and the majority of your big strokes come in very quickly, then you're not going to double your volume in the late window. But if you're a place that gets a lot of transfers like we do, then you could expect to double your window as long as people are screening. The other reason not to increase the numbers is because the patients are being missed. And that's what's happening worldwide, right? If you look at all the late window stroke patients who potentially could have had the Diffuse 3 type benefit we talked about, the majority of them are not going to see fusion or an MRI scan to identify them. So we've got a long way to go to be able to increase the imaging so we can capture as many of these as possible. And the last point I'll make is that we did do a follow-up diffusion perfusion scan on everybody 24 hours after they were enrolled in the Diffuse 3 trial. So in the medical arm patients, the ones who didn't get thrombectomy, we were really interested to know 24 hours later, which on average was 37 hours after last known well, what percent of patients still have a mismatch at 37 hours? And among the Diffuse 3 medical cohort, it was 20% of those patients. Okay, so that would mean overall, maybe about 10% of MCA and ICA occlusions being imaged at 37 hours could have salvageable tissue. And of course, nobody is imaging patients who come in 2 days after a stroke, but we've been doing that over the last couple of years, and we've seen a few patients, right? Again, it's not going to be a lot because it's only about 10%. We've seen patients who've had mismatch in that late window, and we treated patients and had, really, really nice outcomes. So I think this is something that we want to study more in the future is, no arbitrary time windows. You take the picture when the patient comes in, and if there's salvageable tissue, then you go for it. But of course, you're looking at 80% very early, dropping to 50% by 12 hours, and then maybe dropping to 10% by 40 hours. Of course, the sooner you get to them, the more we'll have salvageable tissue. Any other questions?
En la era de la trombectomía, la exitosa como la trombolisis intravenosa.
Could you repeat it? The translator would like one more shot at that one.
En la era de la tan exitosa trombectomía, basada en criterios de 24 horas, ¿cuál es el rol de la trombolisis intravenosa? Que también ha demostrado beneficio basado en criterios de espacio hasta las 9 horas. Entiendo que si el centro no tiene uno va a ser asesor de la trombolisis, pero para el control de la trombolisis, el centro que tiene disponibilidad de trombectomía rápida.
Yeah, that's a great question also. And that's something that we're going to talk about tomorrow, because I have to talk specifically on that. What I'd say is that there is still some debate among some interventionalists whether they think the TPA is useful even in the 6-hour window. And there's a couple of trials going on right now. One of them is called Swift Direct. We're trying to see whether if you skip the TPA, will you get the clot out faster? And that's the idea. Maybe I'll get the clot out faster if I forget the ER, go straight to the cath lab. My feeling is that those are not going to be positive trials. I think the TPA is useful. And again, that's part of my talk for tomorrow. But I think that it can improve the TINKI-3 rates, and it can deal with some distal emboli. And that in the analyses that we've seen that having that combination is a good thing. That's what we're doing in the timeless trial. And just to answer your last question with some data and a picture, I just wanted to show you one case, if we can get the lights down, because I think it's really interesting to see how infarcts evolve, and getting into your question about the very late time window. So this is one of the control patients who was in the medical arm of diffuse 3. You can see she's got a beautiful mismatch, but she has very good collaterals, and you can tell that because despite an MCA occlusion, an M1 occlusion, the Tmax 6 volume is only 41 ml, and it's full of holes. See all the little holes in there? Those are the good collaterals, getting blood in there. But she got randomized to the medical arm, so nothing was done with her MCA occlusion. And then look what happens to her Tmax lesion over the next 24 hours. So it's 41 mLs with a lot of holes here. We leave that MCA occluded. We take a picture 24 hours later. It's now 77 mLs, and a lot of the holes are starting to fill up. What you're seeing is collateral failure. Collaterals don't last forever, and that's one of the messages from the control arm of both diffuse 3 and Dawn, is these patients eventually develop big infarcts, and only 15% of them do well. Come in with an MCA occlusion in the late time window, only 15% are going to become non-disabled by 90 days. So look what's happened to her. Remember, her diffusion lesion was only 5 mLs. It's grown 20 mL, so it's now 27 mLs, and here she is at 24 hours follow-up, more than 35 hours after she was last known well, and she's got a mismatch that's 50 mL. And on average, the mismatch was 100 mL when people came into diffuse 3, and on average, over the next 24 hours, it had dropped in half. So this is a very typical case. She's now got 50 mL. So, you would think that an infarct would be completed by this time, but it's not. So the question is, at this point, we would be predicting that that infarct is going to grow into that 77 mL hypoperfusion lesion. So here she is 3 days later, and there's her 70 mL infarct. So if you look at this, here's a diffusion lesion without the pink overlay, and watch as it grows. And what you can see here is this is not edema. And that's what a lot of people used to say, oh, you're just seeing the edema. But watch the cortex. Look at the temporal lobe. This is cortical tissue that's going on to infarct over 2 to 3 days. So again, this is a really new concept in stroke, is that these strokes are dynamic, and we have the opportunity to use all sorts of therapies to intervene at many different time points. So there's a lot of good that we can do. It's a great field for young people to go into because there's so much therapeutic benefit that we haven't tapped. Even though we're thrilled with the diffuse 3 results, the good outcome rate is only about 50%. That means the other 50%, we need to do something. We need to do more so that we want to have good outcome rates in late window patients that are going much higher. We want to be up to that 75% that you could get in a study like Extend-IA. Yeah.
What's the explanation for collateral fatigue? Why do they stop working?
Yeah, that's a great question. And I don't know the answer. I think even probably better question is, why did this patient have really good collaterals and other patients not? Because it's not age. We see older patients with collaterals and young patients with terrible collaterals. Sometimes the collaterals fail, we think, because of hypotension, right? Their blood pressure drops and we see collateral failure with that. But we see patients' blood pressure looks absolutely fine, and then over time, they just can't support the penumbra, right? The penumbra is usually a relatively short-lived entity, but in patients with good collaterals, it's a long-lived entity, but they don't last forever, and I don't have a good explanation for what it is that tips them over. But they're an unstable, it's an unstable blood flow pattern, and eventually in most patients it goes away. The time that it doesn't go away is when there's spontaneous recanalization. Those are the patients who do well, right? They have good collateral so they can support the penumbra for a long time, and then they're fortunate enough that either we dissolve the clot or it's spontaneously dissolved, and then they wind up doing great. And again, that's a lot of what we see in these mild NIH patients that you were talking about earlier. They've got an MCA occlusion, and they often presented with a big NIH stroke scale, right? In the paramedic, when they had their stroke, they had an NIH of 15. But then they get into the ER, and it's shrunken down to an NIH of 2 or 3 because the collaterals have kicked in. The collaterals don't show up immediately, right? If you scan these patients immediately, you don't see them. But then the collaterals come in, the patients can improve, and then, again, if they have spontaneous thrombolysis, they're going to be great. But if they don't, they often deteriorate in the middle of the night, right? So you know, those are really tough patients to sort out. Other question?
Last question.
It's an English or a Spanish question? Did I break your thing?
No.
Spanglish.
What do you think about using the cushion to exclude patients within the 6-hour window?
Yeah, it's a great question. And again, tomorrow I'm going to give a talk about CTP interpretation. And one of the things that you have to be careful with, not with MR, but with CTP, is that low blood flow has to be low long enough, right? We're marking things as core or estimated core based on having a very severe reduction in CBF. But you can imagine if you have a very severe reduction in CBF that lasts 10 or 20 minutes, and you relieve that, the patient's going to have a TIA. So the duration that CBF is low is very important. So in the first hour, we use a different threshold. We don't use the 30%, we use a 20% threshold. So we tend to be extremely aggressive in the early hour. But on the other hand, if you see somebody at 4 or 5 hours, they have horrible CBF and CBV. So on the dark blue CBF, dark blue CBV, we have not seen good outcomes from those patients. We've tried recanalizing them. These are the patients that we see the highest hemorrhage rate. So it's this very malignant collateral pattern that's pretty uncommon. But when we see that, it does very poorly. We did a study years ago where, of course, you know, the guidelines give IV-TPA to all these people, right? If you come in within 3 hours and you meet the IV-TPA criteria, you're supposed to be treated regardless of what your CT perfusion looks like. But I already told you, we automatically do a CT perfusion as part of our stroke code. So we would treat these patients, and then we went back and said, let's look at the outcome rate in patients who had that very malignant, no CBV, no CBF in that MCA territory, and every case had a Rankin 5 or 6. Every single case that we treated with TPA was Rankin 6. And our colleagues at UCSF said, well, I don't believe that, that can't be true. They repeated the study, they just published it a few months ago, same result, right? So if it's all dead, it doesn't help to reperfuse it.
Terminamos el día, los esperamos todos mañana a las 8:30. Tenemos una mañana muy tensa con muy buenas presentaciones y les deseamos una muy buena noche. Chao.
Right.